Okay, for this lecture, we're going to begin just looking at the basic A&P of the cardiovascular system. As we progress throughout each topic, we will refer back to the concepts of anatomy and physiology. However, I want my students to remember that in your senior year, we don't test over anatomy and physiology. So I'm not going to ask you how many chambers are in the heart. We're going to ask you, your patient comes in, they have left-sided heart failure. What signs and symptoms do you expect? A client comes in and they have a new onset of chest pain. What do we expect to see? Which laboratory results are we going to look at? So while anatomy and physiology is, especially of the cardiovascular system, is very cool, the majority of your test questions are probably going to be from the underlying comorbidities that we talk about in our other lectures. So first thing we want to look at again is blood flow through the heart. So blood comes into the right side of the heart through the superior and inferior vena cava, and it's going to dump into that right atrium. Once it's in the right atrium is going to push it through the tricuspid valve. That's going to be our first AV valve. It's going to go into the right ventricle. It's going to pump out from the pulmonary valve into the pulmonary artery. It's going to pick up oxygen in the lungs, come back through the pulmonary veins into the left atrium, through the mitral valve. It's our second AV valve. Atrioventricular valve, we'll look at that later, into the left ventricle, and that's going to push out the aortic valve and into the aorta. So while we can remember where blood is coming to, it's really important to remember where blood is going to back up to. And that's generally going to happen when we have underlying comorbidities such as heart failure. So if I'm able to just say to myself, okay, I understand that my client has a left-sided heart failure. So that left ventricle, it's a bad pump, and it's not going to be able to pump out a normal volume of blood. It's going to back up. Where should I expect to listen or expect to auscultate signs and symptoms of left-sided heart failure? And generally speaking, it's going to be in the lungs for crackles. And that's how we tie the A&P piece to the actual nursing piece. Okay, so just like we have 4 chambers of the heart, we have 4 layers of the heart. The pericardium, which is the sac surrounding the heart and contains a small amount of fluid. We'll look further into that once we get to our valvular and inflammatory disorders. We have an epicardium, which is the outer surface of the heart, the myocardium, the muscle, and the inside, the endocardium of the heart. When we're auscultating our valves, we're going to want to make sure that we're listening to the AV valves. So your atrioventricular valves are located between the atria and the ventricle, and that is your tricuspid and your mitral valve. These one-way valves help to prevent a backflow of blood. So if you have an incompetent valve, you see that when that ventricle, either right or left, contract, it's going to push blood not only out, but back up. So we are going to auscultate for murmurs. We'll look at that information here in a little bit as well. The other 2 semilunar valves that we have are going to be your pulmonic and your aortic. And they're just called the semilunar valves because somebody somewhere thought that that's what they looked like. So these are going to prevent backflow of blood between the ventricles and the vasculature. All right, so if that doesn't close correctly, especially that aortic valve, then blood is not only going to be pumped out to the vasculature, but again, it's going to be pumped back into the left ventricle, and that's going to make it harder for the heart to work. We'll look at things called stroke volume, cardiac output here in a minute. But again, it's about knowing where blood is supposed to be and where is it going to back up to. So when we do auscultate heart sounds, we normally associate that with the dreaded lub-dub. We're listening to S1 and S2. It's the closing of the AV and semilunar valves. Obviously, when one set of those valves is opening, the other is closing. And so that's how we hear the boom, 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 boom. We're hearing the closing of those valves. S1 is usually your AV valves, and S2 is going to be your semilunar valves. And we'll look at different areas to place our stethoscope, but the little mnemonic here to remember is that all physicians take money. When we listen to it, it's going to be aortic, pulmonic, tricuspid, and mitral valves. And I'll give you a breakdown of what that looks like here in a minute. You can have other things, a bruit and a thrill. Generally, we associate those two things with our hemodialysis patients, which it's cardiovascular, right? They have a shunt, and we're able to auscultate the turbulent blood flow, or we're able to palpate that turbulent blood flow. Well, if you have issues with the vasculature of your heart, if you have issues with the valves inside your heart, you can have these abnormal noises. And that's what a bruit is. It's an abnormal noise that indicates turbulent blood flow. Generally, we're going to refer to that turbulent blood flow noise as a murmur. A lot of our pediatric clients are going to have murmurs because of congenital heart disease. I don't get too worried about a murmur unless it's new, because if it's new, it can indicate that you have some sort of carotid stenosis or other artery stenosis. And obviously, if we have a stenosis somewhere, that means blood isn't getting to where it needs to be, and then you're at risk for decreased perfusion. You're also probably familiar with abdominal bruits, which may indicate a renal artery stenosis, or a AAA, an abdominal aortic aneurysm. So we're going to listen to that, and we can also feel for a thrill. Those thrills are the vibrations that indicate turbulent blood flow. And obviously they're mostly due to a valvular heart disease or arterial obstruction. All right, so if we do find one of these in the abdomen, don't go around palpating on it. You're going to increase the blood pressure to that area, and it's going to cause that higher pressure to actually cause that aneurysm to rupture. And again, we'll talk about that down the road as well. So this is what I'm talking about. To me, it's always been a little counterintuitive, because when we talk about the valves of the heart, it's the semilunar valves are the ones generally that we think of as being on the bottom. So here I have the tricuspid and mitral valve when I'm thinking about blood flow. And then down here we have the pulmonic and aortic. But because of the way that the heart kind of is folding back on itself, when you look at that left ventricle, you normally see that it comes out like this, and then the blood flow portion of it through the aortic valve here kind of comes back across the heart and then out into that systemic circulation. So that's why we're going to listen for the aortic valve and pulmonic valve at the top, even though here it's tricuspid, mitral, pulmonic, and atrial. So it's almost like a backwards from the way that we think about the illustration of blood flow. Again, it's just the A&P of the heart. I would say from our perspective, if you're going to have issues, the majority of your issues are going to be here. We're going to talk a lot about aortic stenosis. It's going to be a big one for us. I'm trying to erase that. So all physicians take money. So second intercostal space, second intercostal space, second. So right and left sternal borders. This client is laying down and they're facing me. This is the right side, and this is the left side. All physicians take money, so now we're going to go down to the fourth to fifth. It really depends on where you look or how big your client is or how much cardiomegaly they have. but it's still going to be on the left sternal border side. So right through here, the same place, only further down than I would assess the pulmonic valve. And then last, we have this mid-clavicular kind of line, and that's where we would talk about the apex of the heart, right? And again, that's where generally most of our nurses are auscultating heart sounds. Unless you are hearing something new or different, we're not generally going in and going, oh, all physicians take money. We'll put it right there at the apex of the heart, and we listen for heart sounds, or we take a pulse to give metoprolol or some sort of beta blocker or whatever. Right after blood leaves the aortic valve and goes into the aorta, you can kind of see how we now are branching off into our left, right, and circumflex coronary arteries. So the heart needs its own blood supply, so it gets first dibs. As soon as that blood leaves that left side of the heart, it's going to go to the coronary arteries. Don't expect you to remember much about the coronary arteries, other than if you have coronary artery disease, or if we have ACS, acute coronary syndrome, which is going to develop into a myocardial infarction, right? But what I do want you guys to understand is that your heart is kind of awesome. If you have a lack of perfusion, you may not know about it for years. You can keep going with a stenosis or an occlusion up to 75, 85, 90% before we even experience symptoms of coronary artery disease. Think about all the healthy people that we've seen in the news that, oh, they suddenly passed away, or they had a massive MI and there were no clues as to why this otherwise perfectly healthy person had this myocardial infarction. It's the compensatory mechanisms. Your heart will develop collateral circulation to help maintain perfusion. But then once it goes in a big way. So that was the mechanical portion of the heart. Now let's look at the electrical portion of the heart. We know just from way back when that we have a pacemaker in our heart. That pacemaker is called the SA node, right? Sinoatrial node. Right there we have it, right? SA node. It has an inherent rate of 60 to 100 beats per minute, right? That is a normal heart rate. Anything less than 60 is a brady. Anything more than 100 is a tachy, right? Now, if something were to happen to your SA node, and it could be a myriad of things, right? It could be you've had a massive MI, it's destroyed this portion of the heart, you have sick sinus syndrome, you have all sorts of conduction issues. Then you want to make sure that your heart has an okay AV node, because right after this fails, your heart rate will actually go from an inherent rate of 60 to 100 to 40 over 60. Well, that isn't great, but something is better than nothing. Now, we're going to have to be able to fix whatever caused that, or to give them medication to increase their heart rate, or to do a procedure like a pacemaker to help them increase their heart rate. All right. So from the SA to AV node, we know that we're going to maintain a normal cardiac output as close to reasonable as possible. But we're going to look at other factors inside of your heart that if those two things were to fail, that we can still have some sort of electrical activity. But once we start talking about anything less than that 60 number, when we look at how to calculate a cardiac output, we're going to be able to see how that low heart rate is really going to cause a absolute decrease in how well we are perfusing. All right, so the concepts behind that electrical conduction system are these four kind of awesome concepts. It's automaticity, excitability, conductivity, and contractility. Automaticity. Every cell in your heart has the ability to contract independently, right? They have the ability to initiate their own impulse. That's a great thing and a bad thing. It's a great thing because if something were to happen long term, SA node, I know my heart can keep doing something. It's a bad thing because once those cells become irritated, then we're going to end up talking about dysrhythmias. Mostly, a big contributing issue to those dysrhythmias is going to be hypoxia. Hypoxia is a great reason to end up with some sort of dysrhythmia, whether it be an ectopic beat, such as a PAC or PVC, or some sort of more long-term irritation like AFib or even SVT. Excitability, again, that's how we can move those electrolytes, electricity, electrolytes, kind of those potassium pump things, potassium sodium pump, or like a calcium, potassium, and magnesium. Those are going to be our big ones. And each one of those electrolytes, with potassium being the biggest, is going to have a role on how well my heart contracts or doesn't contract. So just like with automaticity, we have conductivity. So if I have one cell that is able to contract, they're able to initiate their own impulse. That means we can send that impulse down through the rest of the heart. So we have conductivity. We can transmit our impulses to another cardiac cell. And then contractility. That's exactly what it sounds like. How well do those cells contract? If those cells get too big, if that heart becomes too enlarged, we lose pumping and we lose cardiac output. So that is really the fundamental pieces to the cardiovascular system as far as the heart itself is concerned. Generally, when we're talking about it, we've said I have a pump issue or I have a volume issue. We're going to look at how well your body is able to maintain cardiac output. Now, we can do that really easily, which means I can look at the client's map and say, okay, your map is greater than 60, you're probably perfusing. Or more aggressively, in that I can say, okay, I can see that you have pulmonary artery wedge pressure. I can see the blood pressure on your art line. I can see the blood volume on a CVP. So we do have different ways depending on how sick the client is, and we'll look at those other ways down the road here. But to get to that endpoint, your heart and we have to look at certain things. We have to look at our heart rate. We have to look at contractility. Both of those things are a pump issue. We need to look at blood volume and venous return. Both of those things are a volume issue. So we said everything on cardiovascular is either a pump issue or a volume issue. And that's how we're going to look at it when we start talking about cardiac output and cardiac index and stroke volume and CVPs and all those great numbers. But really what it gets down to is, am I perfusing? Okay, so let's look at what this means from a big picture standpoint. When we are talking about cardiac output, that is a technical way to say perfusion. And a normal cardiac output should be about 4 to 8 liters a minute. So that's a lot. That's a lot of work that your heart is doing every minute of every day of the entirety of your life. We're taking 4 to 8 normal saline bags and squeezing that out in a minute's time. So when we are thinking about that, what your body's doing is it's taking that volume, the stroke volume, which we're going to say should be about 60 to 100 milliliters. You see some things that are different, maybe 60 to 80, 50 to 80, whatever it may be. I use 60 to 100 because I think it's real easy to do the math. And it's real easy to remember because that's a normal heart rate. So if I know that my heart rate and my stroke volume are kind of matching when I'm working, I can kind of generally think about what's going on in that person's body. So stroke volume is actually going to be related to something that we're going to look at extensively when it comes to heart failure called an ejection fraction. So say I have a volume, not a stroke volume yet because it hasn't gone anywhere, but I have a volume of blood coming into my left ventricle, and it's 100 milliliters. My heart squeezes. Not all of that blood is actually going to leave the heart. So if 60 milliliters of that 100 milliliters is pumped out with each contraction, I have an ejection fraction of 60%. And it's 60 into 100, 60%. And then I have that residual volume left over, and that's why CPR is so important. And we've changed CPR from airway breathing circulation to circulation airway breathing. So we have that now. We have that volume of blood, that stroke volume. We're going to relate that to an ejection fraction later on. And then we have how well your heart is pumping. And we measure that simply by looking at the heart rate. So now I can look at my overall cardiac output. So if I have 60 milliliters as my stroke volume, and my heart is beating 80 times a minute, beats per minute, I have a cardiac output of 4.8 liters a minute. So that will give me an overall cardiac output of 4.8, which is where I want to be. It's right in the sweet spot. And we'll look at things that are going to affect cardiac output and how we put this big picture together. So we're looking at preload first. Preload is a nice word for volume. So when we're looking at issues with volume, obviously we have too much or too little. It's going to be the same way with the pump. So this preload, this volume of fluid coming to your heart is going to be increased, obviously, if you have too much circulating volume. A lot of the times, heart failure, obviously, will cause a backup of fluids. We have a bad pump, which leads to bad volume. You will also have issues where maybe you are taking care of a client, and the client is coming in with an exacerbation of heart failure, yet for some strange reason, the healthcare provider has them on 150 milliliters of normal saline. So we have actually caused this fluid volume excess. Clients just typically in fluid volume overload, if you think about your renal clients or clients who are taking vasoconstrictors, things that are going to cause elevated blood pressure. Decreased volume, which is probably a little more common. We were used to dealing with decreased preload because we are seeing clients that are hypovolemic, dehydrated, clients that have issues with a mitral valve stenosis, clients who are on either nitrates or diuretics or vasodilators, so medications, vasodilator, anything that they take, anything from an ACE to an ARB to a beta blocker to calcium channel blocker, anything that affects the blood pressure, because you also have a lot of these medications that will also slow down your heart rate. So we're kind of playing that constant back and forth battle. Clients that have an underlying disorder called cardiac tamponade, or clients that have a history of pericarditis. So that was the pump side of it. Increase, decrease, preload. Now let's look at afterload. So afterload is just arterial resistance. That's how just the A is for arterial. Increased afterload. You're going to have elevated blood pressures. So you have increase in the systemic vascular resistance. And that's another way of saying you have vasoconstriction in your arteries, SVR. And that manifests as hypertension. Clients that have an issue with an aortic stenosis or some sort of impediment, clients that have polycythemia, which means they have too much of everything, so they have this really thick, viscous blood, or clients who are on vasoconstrictors. Again, a decreased afterload is probably more common to us. Hypovolemia, especially clients with sepsis, massive infection causes massive vasodilation. And then obviously clients that are on vasodilators. Say the client who comes in and saying, yeah, I doubled up on my blood pressure pill because my blood pressure was really high, and now we've artificially lowered it to the point where they were confused, lethargic, dizzy, whatever it may be. Now they've come in with those underlying signs and symptoms. But the big piece is still going to be about perfusion, and it's a pump issue or a volume issue. Cardiac index. So I added cardiac index because I can actually find cardiac index on the NCLEX test plan right now. So I want you guys just to understand that basically it's just cardiac output, but it's a more precise measurement. Cardiac index is your cardiac output divided by the body surface area. Because we said 4 to 8 liters is a normal cardiac output. That's a huge range, right? And it really depends on the person too. I don't necessarily think that my client who comes in 85 pounds soaking wet, adult client, is necessarily going to have a cardiac output of 4 to 8 liters per minute. So this gives us a better diagnostic tool when we actually can use your cardiac output. And usually cardiac index will be more of an ICU type of thing. I don't hear a whole lot of cardiac indexes being used just even on step down. But again, it is on the NCLEX test plan. Normal range for us is going to be, again, just 2.5 to 4. And it's just body surface area. We've already discussed the ejection fraction a little bit, right? That's that percentage of that blood. So whatever that total volume is, we gave the example of 100 milliliters, and your EF is 60%. You pumped out, your stroke volume is 60 milliliters, which is perfectly normal. All right. Your ejection fraction is an indicator of your ventricular performance. And it's going to be a great diagnostic test for our clients who have heart failure. When we look at a TEE, transesophageal echocardiogram, or a TTE, transthoracic echocardiogram. Other things that I can look at to help me as a nurse is a pulse pressure. It's simply the difference between the systolic and diastolic blood pressure. And we know the normal blood pressure is 120 over 80. So you're looking at somewhere of a normal around 30 to 40. It's a good indirect indicator of stroke volume. What we don't want to see are these widened and narrowed pulse pressures. And what do I mean? If my blood pressure is 90 over 80, that's a narrowed pulse pressure. It's 10 millimeters of mercury difference. That's very bad. My heart is not getting enough time to contract or relax effectively. I also don't want to see a blood pressure of 180 over 40. That's a very large number to overcome. When we are taught hypertension and we're taught early cardiovascular issues, I generally get from students that nobody ever talks about what is too high. And really, this is going to be one of our biggest depends is the number that is too high is the number that the client starts to become symptomatic. Long term, we can't have that blood pressure be so elevated that it's going to cause that target organ damage. So when we talk about it just from a clinical judgment area, we just need to understand narrow is bad, widened is bad. So usually anything greater than 100, 110, 120, you're going to see different numbers. You're starting to think, okay, things are not going my way. A CVP, you're going to see a central venous pressure. This is actually more common now than the pulmonary artery wedge pressure. I think I've read somewhere in the literature lately that since like 1994 to 2000 and it's either 4 or 14, the use of pulmonary artery wedge pressures, the SWAN GANs, the really high speed ICU has like almost decreased. I want to say it's 65-70%. So we've started using just more of the CVPs. We don't have to thread the catheter all the way through the heart, increasing your risk for dysrhythmias and all that other bad stuff. But we are still looking basically at the same information, and it's about how much volume. The CVP is obviously going to be the one in the right atrium because it's a central venous pressure. And it's going to give us an estimation of preload and the pressure inside that right atrium. We are going to use 2 to 6. And I'm not going to say 2 to 6 is going to be in every book. I have seen 0 to 10. I've seen 0 to 12. I've seen 2 to 8. We are going to use 2 to 6 because that is what I find allows me enough leeway to figure out whether the client is wet or dry. Because that's really all that we're talking about. If I have a really low CVP, the client is probably dry. And it doesn't matter if it's less than 2. If their normal CVP is 8 and now their CVP is 3, they're still dry. All right. So we look at that number just to tell us wet or dry. We have a sick or an injured client with a CVP that is less than 3. We assume them to be volume depleted and may be giving fluids with relative safety. But hold on, it's cardiac, so it depends. If I got a client who comes in and I've already got them on a continuous infusion of fluids and they've been on this fluids for a while, and I'm looking at the monitoring and the CVP, obviously this is going to be in some sort of ICU, critical care area. I got you 150 milliliters an hour, and your CVP is still 3. I need to ask myself, where is that fluid going? Because you should not be dry intravascularly, right? Because normal cardiac output, we said, 4 to 8 liters per minute. So if I've got you at 150 milliliters per hour, it doesn't take very long for that volume to increase. So it's going somewhere. It's just not participating in perfusion anymore. So I would start to look for edema or start to listen for crackles because we're giving them the fluid. I just don't know where that fluid's going because the CVP is still low. Vice versa, if your client has a really high CVP, they're at increased risk of fluid volume overload. And the example that I will give you for this is your burn client. If you have a burn client who comes in and we know that one of the first things that we're going to do is give them a volume of blood or a volume of fluid, whatever it may be. Initially, it's because all that other fluid that was in their vasculature has gone into the interstitial spaces or third spacing, whatever. But as that body starts to recover, what's going to happen is I'm giving you a really, really, really high amount of fluid, but then that fluid that is in the interstitial spaces is going to start coming back into the vascular spaces, and now I've just increased their risk for fluid volume excess. So it really is, from our perspective, as a nurse's perspective, going to be vitally important that you are looking at those parameters and you are evaluating what is happening. don't get in the habit of just, oh, it's wet or dry. Really think about how long the client has been there, what interventions have been done, and how is it affecting the client overall. Right? Because we know everything in cardio, for the most part, is either a pump or a volume issue. If you can ask yourself that on every question, then you will probably come up with a good answer. Because when we get down to these acute situations, the big issue is, am I perfusing? Bad pumps, lots of reasons to have a bad pump. History of acute coronary syndrome, myocardial infarction, history of heart failure, inflammatory valvular disorders, volume-related issues. Usually it's going to manifest as pulmonary edema or fluid volume overload. And so we have to think about that. Am I doing what I need to do to fix this client's underlying condition? All right, so this is a lot. I'm not going to lie, I debated putting this in here over and over, but the more I look into the NCLEX test plan, the more it talks about CVPs and wet or dry. So what do we need to actually look at when we're talking about a decreased or an increased preload? Well, it's wet or dry. We've talked about that. But notice in the red, under decreased preload, we talk about if they're dry in the presence of a continuous IV fluid, we really need to figure out where that fluid is going, because they're still going to have a low cardiac output. They're not going to be perfusing. If you're not perfusing, you're going to assess for changes in LOC. You're going to listen for murmurs. Maybe they have that aortic stenosis. If you are not perfusing, your body is not going to make urine. So you're going to look for changes in urinary output. And obviously, for treatment for a decrease in volume is going to be fluids, especially once we get into shock. Or it's to treat the underlying cause. All right, so if it's blood loss, it's dehydration, is it shock? If I fix the pump, is it going to fix the volume? Or if I fix the fluids, is it going to fix the pump? We look at those things. Increased preloads, now we're too high, so we're wet, especially in the presence of continuous IV fluids. And I am not joking at all. You can probably go to any floor on any unit and ask a nurse to tell you about a client that they got admitted with acute decompensated heart failure, and the healthcare provider had them on a really high dose of fluids, and then they had to come back and start diuresing them because of that. You're still going to be able to assess for changes in LOC, but now because of the pulmonary edema, because of things backing up, I can expect to have a shortness of breath. I could still have swelling, edema, third spacing, crackles, and my treatment is going to decrease the resistance that they have to overcome. So less resistance, less afterload makes it easier to push out preload. I can, of course, give diuretics, but mostly it's just treating the underlying cause. Afterload, we said, is basically the resistance that the left ventricle must overcome. If you have decreased afterload, you're going to have a low blood pressure, probably initially a low blood pressure and a high heart rate. You're going to have a low cardiac output, and notice most of what's in red has stayed the same because it's still the cardiovascular system. So low resistance means a decrease in urinary output because your cardiac output is low. You're going to treat it with IV fluids and treat the underlying cause. Increased resistance, your hypertensive crisis, your blood pressures that are too high. You're going to have a high blood pressure and a high heart rate initially. You're still going to check for changes in LOC, shortness of breath, edema, crackles, and the treatments are basically the same. So although these terms are they're different than what we're used to from other aspects of nursing, it's still just talking about volume and resistance, fluids, wet or dry. You just have to put them in terms, into nursing or into medical terms, when you start to hear people talking about preload and afterload. The best one that we are probably going to use, for those of you not going into the ICU, is going to be the MAP, the mean arterial pressure. And this is another question I would ask myself on any test question. If I wanted to get down to whether or not this client is perfusing, I want to start with what is their MAP. Normal MAP is going to be 60 to 100, and that's a good jumping point for us to look at perfusion. So we'll look at some examples here. MAP is influenced by cardiac output and systemic vascular resistance. That's SVR. So everything is going to depend. And you are going to be doing some titrating of medications to increase or decrease that mean arterial pressure. So I like to use as I was saying, I like to use, it's 1/3 of systolic minus diastolic plus the diastolic. And that's this one down here. And the reason that I like to use this one versus the other one, and I don't care which one you use, I know some people are taught early on, is because if I know that basically in the end I'm adding back in this diastolic blood pressure, that is a good jumping point for me. So if I already know that my diastolic is greater than 60, I'm probably perfusing. And then I just have to ask myself, well, is it too high? If I do the math, is that MAP going to be too high? But there are certain things that we can do to just help us figure out what the MAP's going to be. So let's look at some examples. We talked about mean arterial pressure is just looking at how effectively we're perfusing. We want to keep a MAP of 60. And again, this is going to be, I just use 60 because it's a nice number. Normal heart rate is 60, and it's not going to be true for every healthcare provider. It's not true for neuro. You might be looking for a MAP of 65. But a lot of that is just going to depend on what your healthcare provider's preference is. We do know that if a MAP drops below a certain point for an extended period, that you're basically causing ischemia and or infarction to the heart. You are not able to perfuse your cerebral tissues, and you're going to have changes in LOC. Your MAP is your best indicator of perfusion. So, here's what we're talking about. 120/80. Easy. I can look at this and I say, okay, my diastolics are already greater than 60. Not a whole lot here that I have to do. Where it becomes tricky is when you have these blood pressures that are close. So am I perfusing a blood pressure of 120/80? Yeah, of course you are. It's 1/3 of systolic minus diastolic, so 1/3 of 40, plus the diastolic. So you about 80 plus 13, 93 is your MAP. When I look at these ones, I'm like, oh my goodness, it's 85/55, or it's 90/40. And it doesn't seem like such a stretch, but when we look at the MAP, it makes a ton of difference. So I can see when I did this 1/3 of systolic minus diastolic plus the diastolic, I'm right at 65. The 85, am I worried? Yeah, probably. Anything less than 90 systolically, I'm starting to think long term that this client is at risk for decreased perfusion, but it's cardiac, so it depends. I know clients that can live here, and they're perfectly fine. And then if I look at 90/40, is that client perfusing? No. Now, if I just gave you example B and C here on an exam and said, which client should you see first? If you just looked at this, you may have picked this 85 over 55 versus picking this 90 over 40 based upon the systolic number alone. That's why it's so important to do the math on anything where they give you a blood pressure. Because everything in cardiovascular is perfusion, perfusion, perfusion. Every test question for cardiovascular. Most everything for my content are acute situations. And again, I'm going to be the one to tell you if it's an acute situation. It'll be in the test question, generally speaking. NCLEX will tell you that it's an acute situation. So when I'm looking at this and I see that this client has a heart rate of 38, and my first question is this client perfusing? Probably not. Right away I can look at this and I can say I have an issue with the SA node and I have an issue with the AV node because it's less than 40. Inherent rate of the AV node is 40 to 60. So then I'm going to stop to think, okay, one, is my client symptomatic? Well, what am I going to look for? I'm going to look for changes in LOC. I'm going to listen for crackles. I'm going to look for shortness of breath, tachypnea. I'm going to see if they're cold and clammy. I'm going to want to know what their urine output is, and I want to know what their pulses feel like, especially if they're weak and thready, or weak and pounding, or bounding and pounding. I know that something isn't right. So I'm going to ask myself, is my client symptomatic? The next thing I need to ask myself is, did I do this to them? And how would we have done that to them? Well, most of the times it's going to be because of medication. And then we are giving them medications that have either a direct or an indirect effect on the blood pressure, but they also have either a direct, such as a beta blocker, and you're supposed to get an apical heart rate with every beta blocker, or something like a calcium channel blocker, where we don't in EPIC or on the MAR tell you to get a heart rate, but a calcium channel blocker will slow down conductivity. It slows down how fast your heart beats indirectly. So if I'm giving you those medications and all of a sudden I'm seeing this heart rate of 38, I probably need to be asking myself, what do I want to do the next time this comes up? What am I going to do to treat this heart rate of 38? And we'll look at that when we look at our Brady arrhythmias. So just some quick cardiovascular assessment tips if I'm looking for fluid volume overload or fluid volume deficit. Fluid volume overload. You have high blood pressures. Long term, that's going to be deadly. You have a consistent history of hypertension greater than 140 systolic. You are at increased risk for hypertensive crisis. You can see anything basically 180, 200, 210. That's going to increase your risk for stroke. You're going to have increased issues with CVP. Fluid volume overload is an increase because you're wet. Bounding pulses, JVD. Fluid volume deficit. The client has a low blood pressure. They are experiencing dizziness with position changes, so we might be asked to obtain a set of orthostatic hypotensions. They become lightheaded and dizzy when standing. They have a decrease in central venous pressure. They have weak and thready pulses. They have flat neck and hand veins, and probably are tachycardic. So I really enjoy these nursing camp notes. It breaks it down. It makes it make sense for me. But the big takeaways from this hemodynamic is your blood pressure. Any blood pressure, systolic blood pressure less than 90 should be investigated. Any MAP less than 60 should be investigated. Low CVPs and pulmonary artery wedge pressures with fluid. Ask yourself, where is the fluid going, because it's not participating in cardiac output. So you can see here, even based upon what I said to what now Nursing Camp says here, we use 2 to 6, they use 0 to 8. That's going to be every book everywhere. We see their ejection fraction over here is greater than 60. Pulmonary artery wedge pressure is pretty normal. It talks about SVR here. It talks about stroke volume. They use 50 to 100. I use 60 to 100. It talks about cardiac output here. They're still using 4 to 8. Systolic, our normal is 190 to 120-ish. Pulse pressure, you still got a good number there. And you got your normal diastolics and your normal maps. But it just helps me break down all of that material into quick little tidbits that I can process.